Hello, my name is Maya Tarasenko, and as Dr. Freed said, today we'll be talking about an age-old wives' tale, which I'm sure some of you have heard for most of your lives from loved ones and friends, which is stop cracking your knuckles, it's bad for you. Maybe hard to read, but through my research, I came to realize how annoying knuckle cracking is considered to be. It did not take that much research or self-introspection to understand why. So the theory is that cracking your knuckles will generate enough force to damage your cartilage, thus causing osteoarthritis. And here's the actual mechanism. It has to do with bubbles. So gases, we all have gases dissolved in our synovial fluid within our joint spaces. As we manipulate our joints or crack our knuckles, those gases that are dissolved will form bubbles with that negative pressure vacuum. The bubbles collapse, thus forming that cracking sound that we know and some of us love. This is why you cannot re-crack your knuckles right away. It takes time for those gases to redissolve into the synovial fluid.
So on the screen, this is the finger bone, and this is the knuckle joint just here. So it's looking in this gap. This is the bone comes across the gap, and this is the head of the bone in the hand. Okay, so we're looking in this gap just here. Okay, so you're getting ready. There we go.
So there's the MCP
oh,
joint.
That was beautiful.
And you see that
there's something white popped up
there.
in there when we did it. Okay, we'll talk about that in a minute. Let's do another thing, and here we go. There we go. Oh, that was lovely. Try the last one. There we go. Okay.
Hang on. Okay, if I hold it there.
So on the screen.
So essentially what you're seeing is ultrasound imaging, real time of someone cracking their knuckles. You see those bubbles, that hyperechoic focus as the knuckle cracks. And this helps the theory, basically explaining that bubbles are the reason why you're hearing your knuckles crack as you manipulate them. So while the wives' tale, I'm sure, predates this paper by quite some time, this is some of the earlier findings or research that I had found on my search on knuckle cracking. This was published in a 1989 edition of the British Medical Journal. Up above, you see habitual joint cracking and radiological damage. And just as a fun little aside, you can see it's printed just above laparotomy for 250. If we look a little bit closer, essentially what this is telling us is that it's a case report looking into a 25-year-old Malaysian man who was a habitual knuckle cracker. He had no signs or symptoms, no obvious abnormalities, but on X-ray, they found ligamentous ossification and chondrocalcinosis of several of his MCP joints. Notably, there was no evidence of osteoarthritis. Because he was healthy, because there was no underlying disease that they could, diagnose, they suggested that it was the knuckle cracking that caused this radiological damage. And hence the publication that habitual knuckle cracking will cause radiological disease or damage. That is bad news for the 25 to 45% of people who self-identify as habitual knuckle crackers. So we're going to dive into some more studies to see if that previous one is in fact true. Here's a study from 2011. It was published in the Journal of the American Board of Family Medicine. It was a retrospective case control study looking at 215 subjects, all above the age of 50 years old, who had gotten an X-ray done of their right hand within the last 5 years. On X-ray imaging, it showed that 135 of them had evidence of osteoarthritis, while 80 did not. All 250 received a questionnaire asking which joints do you crack, how often do you crack them, and then screen for some other OA risk factors. And this is what they found, that the most commonly cracked joints did not correlate with the joints most commonly affected by OA, as you can see listed up above. Some more information, the prevalence of knuckle cracking did not differ between the two groups, the group with osteoarthritis and the group without. And then just as an addition, they decided to calculate the number of crack years, similar to pack years, with the hypothesis that they expected a dose-response relationship between one's extent of knuckle cracking and the severity of somebody's arthritis. Again, they did not find an association. This is probably my favorite study. This was done by Dr. Donald Unger, on Dr. Donald Unger, who was a rheumatologist, and he called this a self-controlled study. This was ultimately published in a 1998 journal edition of the Journal of Arthritis and Rheumatology. Dr. Unger spent 50 years exclusively cracking the knuckles on his left hand. He cracked every single knuckle at least twice per day, deliberately not cracking the knuckles of his right hand. And he found that after 50 years, there was no evidence of arthritis, no symptoms of arthritis on either hand, one worse than the other. This study is, yes, a little older, but probably one of the larger ones. They took 300 patients, 74 of which were considered habitual knuckle crackers. And these patients were analyzed for quite a few variables, from social history, medical history, risk factors, and this is what they found. Table 1, you can see that you have your column of habitual knuckle crackers and then your non-crackers, and you see all the variables that they analyzed. And I highlighted the main topic, what we're talking about today, which is osteoarthritis. There was no significant or statistical difference between the two groups with respect to osteoarthritis, nor any of the other variables listed up above. Table 2 shows some significant differences. One was hand swelling. The habitual knuckle cracking group tended to have more knuckle swelling as well as decreased grip strength. You can see down below, they also tended to be, or more likely to be smokers, use alcohol, and bite their nails. And that kind of makes sense because all of these behaviors are habitual. And thus, this 1990 study concluded that although habitual knuckle cracking does not relate to arthritis, it may relate to decreased hand function. So far we've talked about 3, maybe 4 studies that show no evidence to suggest that knuckle cracking has to do with arthritis. Here's one more study, a 2017 prospective comparative study, and this is looking specifically at knuckle cracking and hand function. So they analyzed 400 MCP joints on 40 adults, 30 of which were asymptomatic habitual knuckle crackers. Every subject completed a quick dash questionnaire, which we'll talk about, and then were examined by 2 blinded orthopedic surgeons and 2 MSK radiologists. They looked into swelling, grip strength, and range of motion, and then looked at ultrasound imaging before, during, and after knuckle cracking. This is the Quick Dash questionnaire. It essentially quantifies one's pain and hand function through a number of questions. For some of them, how much difficulty do you have opening a tight jar, using a knife to cut food, etc. And the study found that really there was no difference in hand function in the knuckle cracking group and the non-knuckle cracking group. Quick Dash scores were similar. Grip strength was similar. The only thing of statistical significance was passive range of motion post-knuckle cracking. The habitual knuckle cracking group tended to get a little bit more range of motion after cracking their knuckles. I won't belabor this because we talked about it at the beginning, but essentially here's more ultrasound imaging showing that 81% of knuckles that cracked showed this positive finding up above. 95% of knuckles that did not crack did not show that finding. That's about it for knuckle cracking. I'll pivot quickly to talk about something that was published this week in the LA Times, which I found really interesting. And it's a story about pulse ox devices. Essentially, studies, this isn't necessarily new information, but becoming more and more relevant, especially in the wake of COVID and how often these devices are used and how we utilize them on a daily basis. Essentially, pulse oxes are overestimating SpO2 in patients with more skin pigmentation. And the reason is oxygen-rich hemoglobin tends to absorb more infrared light, which suggests that someone is oxygenating well. The problem is melanin does the same thing. So this introduces the concept of occult hypoxia. Essentially, clinics are seeing that patients are coming in showing they're oxygenating well, over 90%, and then they'll get an ABG and find that that's actually not the case. This tends to occur 3 times more often in our Black patient population than our white patients. This is, of course, dangerous to people's health. This is also a logistical challenge. Many insurance companies will not cover certain things like home oxygen therapy or ambulance transfers if someone looks like they're satting perfectly well. There's not much being done. There's very little regulation about this currently. There's FDA recommendations, not requirements, for pulse ox device companies that say, if you are doing a clinical trial, we recommend at least 2 of your subjects or 15% of your total participants are darkly pigmented. That is very ambiguous language, which device companies can use to their discretion and interpret however they would like. There's also no requirements for device companies to label these devices saying, hey, this may be defective for certain patient populations. So I thought this was kind of interesting and something that we can keep in mind because I know how much we utilize and depend on pulse ox devices. Short and sweet, that is essentially my presentation. Let me know if you have questions.
Any questions or comments? Oh, nobody? Nothing? I don't really have any comments about the knuckle cracking. As far as the pulse ox stuff that you presented at the very end, it was a really big issue during COVID. And I think that if you read the article in the LA Times, which did come out like just a few days ago, I was on the front page. I was really surprised when I saw it. But one of the more surprising things to me was the fact that they quoted a pulmonary critical care physician that made it sound like it was news to her. And, you know, it was like, or up until COVID, it was news to her when some of the studies started coming out. I'm thinking, you know, we've taught this to every resident that we've trained here since 2004, if not before then. We talk about it in the FCCS course in the orientation week, how pulse oximeters are not as reliable in darkly pigmented people. But one of the things that I found interesting when I was kind of doing a quick review of stuff, one of the first studies that came out during COVID that really talked about this, they actually found, and this was a surprise to me, that Asian patients actually had more of a discrepancy than Black or Hispanics. A lot of times everybody's always focused on the Black and Hispanic, and they don't talk about the Asians, which was really curious to me. I don't know the mechanism of that because it's supposed to be related to melanin, but I just thought that was really interesting on that. Okay, so we're going to vote now. It's a myth that habitual knuckle cracking causes arthritis. How many people think this is true? They think it's still plausible? Busted.